Oh, very quick question because I can't type that quickly. In the intro, it says that Stephen will be leading the discussion on virus evolution. In our population doesn't mean that it's mild, doesn't mean that cases are stable or increasing or decreasing. And is it still too soon anyway to label a virus as endemic in this country when it's still spreading and potentially evolving in large parts of the unvaccinated world? So to help us get some clarity on this, we're delighted to welcome on board our newest member of Independent SAGE, Dr. Stephen Griffin. He's an associate professor of virology at the University of Leeds School of Medicine. Welcome, Stephen. And while we're welcoming new members, I'd like to take the opportunity to introduce another member as well of Independent SAGE, Professor Aris Katsarakis, Professor of Evolution and Genomics at the University of Oxford. So we really welcome the added expertise of both Stephen and Aris, particularly now as vaccines, variants and immunity are absolutely key to understanding what's happening with COVID and in planning for the future. So Christina is going to lead a discussion on virus evolution and hopefully get to the bottom of what endemic really means today with Professor Danny Altman and with Stephen as well. But first of all, Professor Christina Pargler is going to give us the up to the minute facts and figures. So Christina, over to you.
Thank you. Let me share my screen. So also just to let you know that Aris will also be part of that discussion. So we'll have three world-leading experts to talk us through it later. So today I am covering vaccination, cases, hospitals, deaths, and then a little bit on children at schools at the end. So first, just a very quick look at the vaccination data. And basically what I wanted to highlight is that after this kind of massive push to boost people just before Christmas, where we're doing almost 1 million injections a day, since Christmas, it's really, well, it's dropped off a cliff really. And we're not doing that many of any type of vaccination at all now in the UK. And it's not because we're finished. So about 53 to 58% of the population have had a booster. Obviously, children are not eligible, so that accounts for some of it. But we still have about 4 million people who've only had 1 dose of vaccine. Many of those are children, and 12 million on 2 doses. And a lot of those people are adults. So we haven't finished our program. So it really is quite concerning that effectively the urgency seems to have dropped off. Looking at cases now, this is the number of new cases by reported date across the UK. And you can see that over the last few days, it has been coming down. And that is welcome. And if we look at it by nation, this is the number of cases by date of test. And this goes up to last Friday, the 8th of, or Saturday, the 8th of January. And you can see that it looks like cases in all 4 nations have peaked. Note that now, certainly in England, where you don't need a confirmatory PCR and you just need a lateral flow test, it's not obvious that a lot of people will register their test result, whether it's positive or negative. So we're not quite sure how that's going to affect case numbers. The other thing to note is that reinfections, so people who've had COVID before and then test positive again, are not yet included in the England numbers. I don't think they're included in the Scotland's, but they are in Wales and Northern Ireland. So that could explain why they have high rates, because about 10 to 15% of cases now are people who are reinfected. So that's just worth bearing in mind when you look at this. And to me, what is really positive is that the positivity rate, so the proportion of people who test positive, is also coming down in every nation. And that to me implies that it isn't just about testing, that there really is genuinely that we have reached kind of a peak in Omicron. If we look at the ONS infection survey, the most recent week, that is still going up. So to the week to the 3rd of Jan, almost 7% of people in England tested positive for COVID. So again, this is a bit, it's a bit lagged compared to cases in that firstly, it only goes up to the 3rd of January, which is almost 2 weeks ago. And also it's measuring people who currently test positive. So it's not measuring new infections. So that also makes it a little bit lagged. But I just wanted to highlight it because 8%, I mean, that is incredibly high. That is just, you know, almost 1 in 10 people testing positive in England. If we look at it for the nations, it's actually 7% is 1 in 15. All the other nations are at about 1 in 20. So England does have the highest prevalence in the UK. In England, by region, you can see this kind of quite interesting behaviour. So all regions are now coming down. The northeast is the last one to turn, and that kind of makes sense because they were the last to get Omicron. And you can see this here, they kind of started rising the latest. London is really an anomaly. And I think what's happened here is not only did it peak earlier, it peaked lower, say, than the north. And I think this is because it rose really, really rapidly before Christmas and it became a big story, particularly in London. And I think people really modified their behaviour, particularly here around the week before Christmas, to preserve their Christmas. So they wanted to see family or friends at Christmas. And I think that really changed, it really did change the course of the epidemic in London. And I think other regions, particularly in the north of England, where Omicron was much slower to reach, the behaviour didn't change as much. And so they've kind of seen higher peaks and later peaks. The positivity rates are also coming down in every region just now in the northeast. They've been incredibly high, but they are now starting to turn. So I do actually think we have peaked again, but it's kind of happened a little bit later in the north. The ONS prevalence survey has kind of a similar pattern where they show London is the only, London and perhaps the east of England are the only regions that have peaked. And again, they see really high prevalence other than that in the north, west, east, and Yorkshire. So looking at hospitals now, this is the number of people in hospital with COVID per million people in the UK, 7-day averages. And that is still going up. Hopefully it will slow now that hopefully cases are going to come down. But you can see that although no nation kind of has got to its peak from last year, the bad January peak, we are kind of in the same ballpark as we were in the first wave, apart from Northern Ireland, which is higher. So it's actually not that far off the kind of strain on hospitals that we saw in the first wave, except this time we're also trying to provide normal care. What is good news, though, is that the high pressure on hospitals of COVID is not translating into intensive care. So this is kind of intensive care capacity. The grey line is 2019-20, so the winter before the pandemic. This is 2021, which was kind of the awful peak last year, and the red line is so far this winter. And you can see we're tracking the pre-pandemic winter, we're not tracking last January. So that is really good news, that we're not causing a massive strain on ICU this year. When we look at admissions, you can see that they're high, but the last couple of weeks, they have kind of stabilized at around 2,000 admissions a day. That's not that far off the 2,500 we saw at the peak in the first wave. I don't think we're going to get near where we were last January, particularly now that it looks like cases have peaked. I think what is really encouraging is that the ONS infection survey today said that in the first week of January, over 3% of over 70s and 5% of 50 to 69-year-olds actually tested positive for COVID. That's very, very high for that age group, much higher than it's ever been. But it doesn't seem to be translating into a serious surge in hospitals. And that is really, really good news. And that will be because we have really good booster coverage in that population. If we look at hospital admissions by region, you can see kind of the case pattern reflected. It hasn't quite, it takes a bit longer for it to show up in hospitals. London does seem to have peaked in early January. It's coming down now. Other regions are flattening off. It's only really the Northeast that is still going up. But the Northeast and the Northwest are both kind of at levels of admissions that they had certainly in November last year. And actually, they're not that far off where they were in January last year either. So there's a lot of pressure there. And you can see it perhaps more obviously is this number of people in hospital. So in hospital occupancy, and certainly the Northeast and the Northwest are now higher than the occupancy in the first wave. And, within, I don't know, 20% or so of where they were last January. What's causing additional pressure is staff sickness. So the number of healthcare staff off sick has continued to go up in every region this week, apart from London, where it's kind of stable at around 6%. But particularly in the North and the Midlands, you're seeing really, really high levels of staff sickness. And that's actually increasingly due to COVID. About half of these absences are because someone has COVID. A year ago and the year before that, it was around 5%. So you can see it is overall in England, almost 9% of staff off sick. That is causing a lot of pressure. We can also see kind of the consequences for the NHS in ambulance indicators. This is the average ambulance response time in minutes by urgency, where these are the most urgent calls, and then these are kind of the least urgent calls. And this goes all the way back to 2018. And you can see that right now we're at record levels for ambulance response times. It's taking a long time for ambulances to get to people, particularly for the lower urgency calls. But say the C2 calls are actually reasonably urgent, and they're also now taking longer, almost an hour. If we look at just the most urgent calls, so those are calls where there is an immediate threat to life, the target time for response is 7 minutes, which is here. And you can see that actually now we're not meeting those targets. So even for the most urgent calls, ambulances are taking longer. And also accident and emergency is incredibly busy. There's a kind of a 4-hour target that ideally when you go to A&E, you should be seen and either admitted or sent home within 4 hours. Almost or over a quarter of people now take longer than that. And that is the worst it's ever been, significantly higher than previous years, which are these dash dots. So just moving on to deaths now. This is the number of deaths reported across the UK up to yesterday. And it has been going up. I mean, obviously, we are not anywhere near where we were last January. And I don't think anyone thought we would be. But we are now reporting up to almost 400 deaths a day. Now, some of that is because of lags over Christmas and New Year. It's meant that a lot of deaths get reported on the same day. So, but if we look at date of death, so the day someone actually died, you can see this only goes up to the 7th of January because, again, it's a lagged indicator. You can see there has been quite a sharp increase in the last few weeks. So we're now, for the latest day, over 200 deaths in a day. And we haven't seen that since February of last year. So we haven't seen it since we've had mass vaccination, really. And I think that is something that we should be worried about and should be saying this is not acceptable. And unfortunately, that probably is going to keep going up for at least another week or two. So finally, just kind of moving on to children and schools. If we look at the age groups of people testing positive in England, you can see that pretty much every age group is falling quite sharply after New Year, except children. So 0 to 4, 5 to 9, 10 to 14, 15 to 19 are either flat or going up. And it's actually even kind of easier to see if we look at London, which peaked first, where you can see everyone kind of peaking after Christmas towards the end of the year, including school-aged children whose cases went down. And then back to school. And now that 10 to 14-year-olds and 5 to 9-year-olds are really the only age groups in London where cases are going up. And this is going to be an issue this term. And the other thing that we're seeing because of the high levels of Omicron, and actually children at the least vaccinated population, is that we're seeing very high levels of admissions of children with Omicron. This is admissions per day for 0 to 18-year-olds. And in fact, we've admitted almost as many children in the month that we've had Omicron as we did over the whole of the first year and whole of 2020. And in school disruption, we're already seeing, only 3 days into term, more children off school because of COVID than we had at the end of last term. And normally the beginning of term is the time when you have the lowest infections, as you can see here, is quite a steady pattern. So this is actually genuinely really worrying. It's very, very disruptive. 315,000 children off school. And it's not just children, it's also staff. There's a lot of staff absence now from COVID, higher than at the end of last term. And orange is from COVID and blue is other things. And you can see that the proportion of absences that are due to COVID directly has gone up as well. So just to summarise, cases look to have peaked in all home nations, both using case numbers and positivity, which is really good news. Hospital admissions and the number of people in hospital with COVID are very high, but I'm hoping they will be close to peaking soon. But the pressure, while it's not translating to intensive care, is pressuring the NHS because of the really high demand and really high levels of staff sickness. And we know that ambulance and A&E waits, for instance, are at record levels. And we also know that many hospitals are having to cancel surgeries and other treatments. And finally, children, particularly school-age children, are the only age groups where cases are rising. Hospitalisation in children remains at much higher levels than it has been for children in the past. School disruption is already high, and we've only been back at school for a week and a half. And that's both from sick students and sick teachers. And really, without addressing transmission in school, it is going to prolong the Omicron wave. So I will stop sharing there and move straight to kind of tapping into the virology and immunology expertise that we have. So I'm going to start with kind of the question that I think has been in the news a lot recently, is this talk of COVID now being endemic, now that we've got Omicron. So my first question, I'm going to start with Steve, is, what does endemic actually mean? And have we reached it?
Thanks, Christina. Yeah, it's the big question, and we're hearing it everywhere, aren't we? We really are. Endemic, I think, is a problematic thing to talk about in many cases, because what people tend to associate endemic with is an idea that this means that it's no longer a problem. And what it literally means is, and that there are lots of different definitions depending on whether you're an epidemiologist or different disciplines, what have you. But essentially, it means that the virus is there most of the time. The infection is there most of the time, in simplistic terms. And the ability of that virus to spread, combined with the number of people that are able to be infected by it, generally means that the levels of infections in a population stay roughly the same. So you don't see these big peaks and troughs that we're seeing with COVID all the time at the moment. And that can be at a very low level, but it can also be at a very high level. So it's not the same as severity, and it's not the same as disease. It's literally about the number of infections that are happening within your population.
So, Aris, has you got anything that you'd like to kind of add to that?
Yeah, I mean, I think basically Stephen captured it very well. It's a term that has multiple definitions, and it's rapidly becoming one of the most overused and abused terms of the pandemic. And essentially, it's been used in a very information-free way. It doesn't really tell us anything about our endemic future. And sometimes you see policymakers use the word to just sort of say, oh, well, the virus will always be there, slightly shrugging their shoulders and saying, well, there's not very much we can do about it. It's a sort of naturalistic process. And that's not what the word means. It's got a very precise epidemiological meaning. And unless we define what type of endemicity we're talking about, it's not telling us a whole lot about what the future will be like.
So what kind of possible endemic features are there for COVID then, Aris?
Well, I think to an extent, the nature of the endemic future will depend on what we do, both in terms of what the future will look like, but also how we get there. I mean, we could have a situation with a very high endemic set points and very substantial disease burden, if we don't manage to vaccinate the world and to keep infections low while we get to that point. And really the big challenge is to make sure we get to a point where we can have as low an endemic set point as possible by making sure there are as few susceptibles in the population, ideally through vaccination rather than natural infection, and to make sure we get to that endpoint while incurring the least cost in terms of disease and mortality while we get there.
Danny, did you want to come in?
Yeah, can I just chip in with a quick sentence that I felt terribly confused and confounded the last few weeks by the kind of takeover of the word endemic as some kind of aspiration or victory because it means mild, and that's totally thrown me. Because, for example, I spent some years in charge of infection and immunity at Wellcome Trust, and there our big enemies were endemic diseases, and our biggest spend was on HIV, TB, and malaria, the world's killer endemic diseases that were endemic because they were stable and embedded, but also killed millions, but in a predictable way. I don't really understand that as an aspiration.
So can I just ask, so basically, are we endemic now? Is COVID endemic now? Yes or no?
No, absolutely not. No.
Okay. And it does not mean mild. There's one thing people have to take away from this is endemic does not mean mild. Right.
That's right. I mean, smallpox was endemic. Smallpox is endemic. Malaria is endemic, as Danny rightly says. The problem is that people are talking about this reaching some kind of steady state, and they're also reflecting the fact that all the virus really wants to do is transmit. It doesn't really care if it makes us unwell. That virus has been and gone and spread to somebody else by the time it goes down deep into your lungs and causes the severe reactions that we see putting people in hospital. So this notion, which is equally as damaging as this idea of endemic meaning mild, is that this virus will naturally become less pathogenic, is also not true. But there are elements of that we're seeing potentially with Omicron. The jury's out really, but it is not the fact that viruses seek out to become less pathogenic so that they can reach this equilibrium. It's not the case at all.
So even if Omicron is milder, it doesn't mean that the next variant is going to be milder.
Absolutely.
And Omicron doesn't reflect anything about previous variants, or does it? Danny?
Yeah.
Oh, sorry, like Danny.
Danny.
Well, no, I'll chip in. Yeah. So yes. So I think Omicron has been slightly misconstrued to imply that because for reasons that we can discuss if you like, the phenotype appears milder, as in proportion to the number of cases, fewer people are currently hospitalized and dying. That must be some kind of longitudinal trajectory from all the others, and it so isn't. It's a one-off set of mutations that arose presumably in southern Africa, and meanwhile we have many millions of cases around the world and trillions of virions in people's lungs around the world, all generating new variants, some of which will become variants of concern, some of which will have completely different mutations that will have nothing to do with Omicron and won't carry on with an increasingly mild projection. It's just not how it's working.
Aris, would you like to add to that at all?
Yeah, I mean, I think we see all these comparisons about the wave of mortality that the Omicron wave is producing, and I think we're sort of not really comparing like with like sometimes, and the comparison with the Delta wave is made, and Delta is a particularly virulent variant of SARS-CoV-2, and in fact responsible for more mortality than many of the other variants. And actually, if you compare Omicron to its ancestor, it's not at all obvious to me that it has evolved a lower severity. And we really have to remember every time that the severity of the waves being reduced is primarily down to the prior immunity and the vaccination and the prior exposure of the population, rather than any natural journey of the virus down a path to lower virulence, which is by no means what we're seeing.
Thank you. And then just kind of the last question, which is on a bit of a different tack, is on this change that we're going to see, I think, announced next week, that we're reducing the isolation period for infectious people from 7 to 5 days. I mean, what do we know about the infectious period of Omicron and what are kind of the risks of that strategy? Danny, do you want to go first?
Yeah, so I'm sure there'll be lots of comments and lots of data out there, aren't there, on the kind of Gaussian distribution that humans are very diverse, and our interaction with the virus is very diverse, and there are in different studies, whatever it is, the 50% of people who are LFT negative by day 5 or 6, and then the long stragglers out to day 10, and then the longer stragglers further out still. And so if you're trying to manage isolation and your workforce in a country that's got very good use of lateral flow tests, and makes them very readily available, maybe that can work, except that some people will now feel very pressurized to go back to work, perhaps when they're still positive, perhaps when they're still feeling unwell, simply because they have no choice. So it's kind of a solution, but at an enormous cost.
Steve, would you say anything to that?
Yes, I think particularly when people are symptomatic, it's pretty clear that a good proportion of them are definitely still shedding virus longer than that 5-day period. But I think this kind of strategy also is very similar to the idea that cases don't matter, which we've heard regurgitated from time to time. They do matter, for example, in terms of the incidence of long COVID, which we have no idea about for Omicron, and it also matters for clinically vulnerable people. And that applies equally to clinically vulnerable children. And of course, as you showed in your briefing, Christina, the cases are going up again in schools, and we can almost certainly predict that Omicron will establish itself in schools in the way that Delta did. So I think that, again, the policy does not reflect those people that are kind of being left behind by this idea that cases aren't a problem.
Thank you. Well, I think that concludes our questions. So now back to Alice for listener questions.
Thank you very much indeed. And thank you for that really interesting and extremely clear discussion. I think we now know what endemicity is, and we know that viruses, you can't rely on a virus to evolve to become more mild. So thank you very much for that, Danny. We're now going to go straight to questions from the press and public, starting with Julia Smith. Julia, are you with us?
I am. I'll switch my face on.
Thank you. What's your question?
Yeah, so mine's actually, what would be the thresholds whereby it would be appropriate to categorise COVID as endemic? So we've obviously talked about that, but whether there are any specifics that can be given in terms of thresholds.
I'll pass that straight back to Steve then, I think.
That's an excellent question. It's really something that will find itself as a matter of balance. When this balance between the ability of the infection to pass on and the number of people that are susceptible is found, as Aris rightly said, that can be very high, can be very low. And of course, the two things that are competing in that sense are the evolution of the virus and the things that will stop it infecting people, which is primarily our immunity, but also our non-pharmacological, pharmaceutical interventions as well. So there are examples of viruses that are held as endemic because we vaccinate highly, for example, measles. There are lots of viruses, for example, chickenpox, which stay endemic because most adults become immune and they stay immune, and it's only newborn children that are susceptible to that. So really where this is going with SARS coronavirus 2, we don't know, because at the moment, we certainly are not on a global scale ahead of that virus in its ability to change with respect to the sort of hostile environment that we're trying to create by us all becoming immune. So I strongly advocate us vaccinating the whole world where possible and every age group where possible to try and get a handle on this. Delta was in schools, Omicron will do the same.
Thank you very much indeed, Steve. I wondered if you wanted to add anything, Danny or Aris, or are we happy that that is all nicely parcelled up? Okay, thank you very much, Julia, for that question. Moving on now to Richard Harrison. Richard.
Hello. We've heard a lot in the last week or so about the implications of Downing Street parties for Boris Johnson. My question is about the wider implications of this, including policy. What effect do you think the knowledge, either inside or outside government, that there were illegal or at least strongly inadvisable parties in Downing Street during lockdown has had on the ability of the government to impose necessary additional measures to help protect the most vulnerable, in particular during the Alpha, Delta and Omicron waves, and also on the likely effectiveness on such measures now if we want to tighten up any of the MPIs.
Thank you very much, Richard, for that very, very pertinent and timely question. I'd like to come to Professor Stephen Reischer and Professor Susan Mickey for answers here, and then the rest of you let me know if you want to chip in as well. Steve Reischer, could I start with you?
Well, some of the government's critics used to say they didn't know how to organise a piss-up in a brewery. We now know one thing, which is they're very good at organising piss-ups. I don't know if they're very good at organising other things. In terms of the consequences, well, the polling is very clear in terms of the impact on how the government is seen. So by about a ratio of 6-1, people believe that Boris Johnson is lying. People believe that Boris Johnson was at parties. His approval rating, even before the latest revelations, was down as low as 20%, but it wasn't just him, because trust in the Conservative Party was 10%. Now, those are remarkable figures, remarkable figures. You very rarely see such low ratings for a government, even an unpopular government. So it can be said, without, I think, fear of contradiction, that first of all, there is a loss of trust in the government, a loss of support for the government, a loss of influence by the government. People just don't believe what the government and what the Prime Minister is saying. In terms of behaviour, in terms of adherence, it's a more mixed picture. So when you look directly, what you find, as indeed you found after the Cummings affair, was that, yes, there might be a lot of trust, but some of the people who are most angry at what the government was doing are most likely to adhere because they want to say, we're not like them. We go along with the rules. We look after our families and our neighbours and our communities. So people start adhering despite the government, and indeed levels of adherence continue to be strong. And if you look at behaviours over Christmas and the New Year, actually one of the reasons why the figures aren't quite as bad as we thought they were is that people were doing the right thing, that people weren't partying, that people were limiting their interactions to the ones that were really important, being with family. And so one statistic I think is really telling is that over 80% of the population was taking a lateral flow test at least once a week, and nearly half, about 47%, were taking 3 lateral flow tests in a week. People were behaving sensibly despite the government. Having said that, that's not a good look, because in the midst of a national crisis, you need clarity about the nature of the situation. You need clear information from a trusted source about what we should be doing, and the government can't do that. And in terms of policy, I think the most significant loss of influence isn't actually in the population, it's in the Conservative Party itself, because Boris Johnson is no longer seen as a vote winner. He has lost influence within his own party, and therefore he is hostage to a very small number of Conservative MPs on the libertarian end of the spectrum, who aren't prepared to put in place any measures at all, not only measures of restriction, but measures of protection. All the things we talked about last week, like making sure that environments are safe, schools are safe, there's ventilation in schools, making sure that people can afford to self-isolate, making sure that for those 250,000 kids who are missing school, there is actually IT so they can continue to study. All that is being blocked. So if there is an impact of these parties, it's not that the population has given up. Actually, the population, by and large, is continuing to do the right thing. It is a political issue. It's an issue of political influence, and we are basically in a vacuum of leadership. And in the largest crisis of our generation, I think it is a tragedy that we're in a position that we have not only poor leadership, actually by now we have a vacuum of leadership.
Thank you very much, Steve. Susan.
Thanks. Thanks for the question. Well, data show that politicians are always one of the least trusted groups within society. Health professionals are amongst the most trusted. Scientists also pretty trusted. And over these recent months, what's happened is politicians have become less trusted, and actually scientists have become more trusted. And so I think what's really important is, where do people take their advice from? Who do people listen to? Who do they trust when they want to make decisions about what's going to be the best thing for themselves, their families, their work communities, etc.? I think really important to encourage people to look not to politicians in this instance, but to people who they do trust more. Now, one of the problems is the internet. When people go to the internet to try and find advice and information, there's a lot of noise out there. And I think one of the really important things is just for everybody to think, if they are faced with a decision, say, for example, vaccination, who can they turn to? Is it your GP, somebody in your GP surgery? Are there respected people that you trust in your community, possibly faith leaders, people in your own social network that you can go to? And I just wanted to use this opportunity to raise the issue about health professionals getting vaccinated, because February the 2nd, which is only a couple of weeks away from now, is the last time that health professionals who are not yet vaccinated can take their first vaccination and meet the deadline to ensure that they keep their jobs. So it's incredibly important that anybody listening to this who either is a health professional, knows a health professional who isn't yet vaccinated, really encourages them to find somebody they can talk to. And the other thing is that one of the groups of people you can talk to is actually people at the vaccination centre. You can actually go to an appointment and make it very explicit you're only there to have a discussion, to get information. It's not committing you to having the vaccination at that point. So I would really stress this, because I think it's heartbreaking for anybody to lose their jobs, especially such important jobs. And it's also heartbreaking for the teams that people work in. Thanks.
Thank you very much, Susan. Christina, you wanted to comment on this particular question.
I did on the party issue, because I think one of the kind of obvious things that's happened over the pandemic is it's really highlighted the inequalities that we have in this country. And one of those is along deprivation and minority ethnic communities. And we know that they've been more exposed to the virus, and we know that when they get infected, you're more likely to end up either in hospital or with long COVID. And we also know that vaccination rates are a lot lower in those communities. And to fix that, to help protect those communities, we need to build trust. And we're now in a situation where a report was released showing that police came down a lot harder on ethnic minority communities for violation of lockdown rules than they did on white communities. And we're seeing that actually at the same time that, Eid was cancelled, that people were blaming BME communities for not following the rules, and actually at the very top of government in Downing Street, people were having parties, and it now looks like the police aren't even investigating, getting away with it. And I think all that's doing is you're alienating and further telling those communities that they shouldn't be paying attention to the other public health advice. And I think that is a really unfortunate and bad situation to be in.
Thank you very much, Christina. A really important point. I wonder if Dr. Zubaida Haq would like to take that up.
I was thinking the very same thing. Christina got that. No, that's a really important point. And it showed in fines, between March the 27th and something like the beginning of May, sometime the first or second week of May of the first year of the pandemic, there was something like 13,700 fines given out. And a disproportionate amount of those fines were targeted at Black and ethnic minority communities. So yes, there will be a real strong, first of all, a strong sense of unfairness that the public, when they've broken the law, and this is about the law, Boris Johnson apologized, but this isn't an apology issue. having parties during lockdown was about breaking the law. Now, the public have had to face the fine. We know Black and ethnic minority communities, from the police figures about who they've given the notices to, that the fines to, that's been disproportionate. But on top of that, as Christina rightly pointed out, that then raises the question of trust. And we know already that trust isn't great between some BME communities and the police and the government, which is why vaccinations, particularly in relation to government and the public, why vaccinations are lower. So it does leave us in a very difficult position right now. Yeah, I completely support what Christine's saying.
Thank you very much indeed, all of you. And thank you for that question, Richard. I'm going to read out a question now, which is coming from Lisa Forber, who says, it's a really interesting question. As the NHS seems to be coping with this wave of Omicron, does that mean coronavirus is no longer a big deal and that we're really back to normal? Who would like to start with that one? Martin, did I see you? Oh, Steve, Martin. Martin, would you like to start?
Either of us, I guess. No, we're definitely not. I mean, there are so many issues that are still unclear. I think for me, one of the biggest issues is what the long-term consequences of COVID will be, not just long COVID, which of course we have talked about. You know, we just heard, and Anthony was tweeting it earlier, a study that has shown a strong link between Epstein-Barr virus and multiple sclerosis. Now, we've been talking about that since I was a medical student in the 1970s, about a possible viral etiology. And we know that other viruses have got effects which only become manifest many years later. We have enough pointers already to suggest that this is a virus which is going to impact on a number of body systems. So I'm really worried. I'm worried about that. But also, I think we've been diverted a bit because with Omicron, what we are seeing is fewer people being admitted to intensive care units. But that doesn't mean that they're not being admitted with other things. Because this is a multi-system disease. It's affecting the cardiovascular system, the neurological system, and so on. And just because we're not seeing those respiratory problems that take you into intensive care, people in the health service are working flat out. We also have the impact on staff, of course, and staff absences and people having to cover. But the other thing is that people sometimes talk about incidental infections. People come in. Well, first of all, people are coming in and getting infected in hospitals, and that's not something that we want to see happening for obvious reasons. But there are many people who are in hospital with chronic diseases where getting COVID on top of a chronic disease, knowing that it has an impact on diabetic control and on your cardiovascular system and so on, it just makes it more difficult to manage what are already often challenging circumstances with people who've got frailty and multi-system disorders. So and I don't think we're out of the woods by any stretch of the imagination.
Thank you very much, Martin. Steve Griffin, you wanted to comment?
Yeah, I mean, I was going to make a similar point to Martin about the long-term effects, and long COVID, of course, is something that we just don't understand fully. But it's something that I've always been against, really, is this idea of sort of metricizing the pandemic too much in terms of the NHS capacity. Just because you have enough beds for people to be ill in, it doesn't mean you shouldn't try and stop them being ill. And that's been my view since the start. And I just think that we've maybe lost sight of that a little bit in terms of, you know, wanting to move forward and just saying, oh, it's okay, the NHS can cope. And I'd also say the healthcare workers, and I'm not one, I'm a bench scientist, healthcare workers are exhausted. And I think the government are trying to get a little bit too much blood out of that particular stone still.
Thank you very much, Steve. And I wonder, Helen, if we could have your perspective on this as a clinician.
I mean, I think the idea that we're coping is slightly incorrect. If you think about the number of hospitals that have put themselves on crisis footing, on my local hospital and many others across the country have cancelled all non-emergency and non-cancer surgery. So they're only doing day cases and emergencies and cancers. And that means that when we've heard just this week about record waiting lists, and those waiting lists are not just people who are in an awful lot of pain and disability because they're not getting their hips or their knees replaced. There are also things like heart surgery, which can be delayed a bit, but the longer you delay something, the more dangerous it can get. It's not coping. And the deaths that are attributable to COVID and the morbidity, the illness that's attributable to COVID is not just about the people who suffer from the immediate and direct effects of the virus. Even leaving aside long COVID, it's about all the other people who don't get treated because there aren't enough staff there to do the treatment because they're all off with COVID, or there are too many other people in hospital so that people can't go in for booked care. We're not coping. You can have, okay, what are they waiting for? Are they waiting for lots of photographs of bodies lined up in corridors or morgues overflowing? I really don't understand what it is they want to wait for before they will do some of the things that we know need doing anyway, like improving air quality and sorting out masks and providing masks and all the stuff that we could do that would reduce the number of people getting this illness. And they could have done it ages ago, and they haven't, and they're still not. And I'm afraid it makes me really angry because I see my patients yet again having their care postponed when they can ill afford it.
Thank you very much, Helen. I mean, it's such an interesting and important question, isn't it? Because it is about the future, and it's about where we kind of see ourselves now, but also in the future. But if we think that this wave is acceptable, does that mean that we are expecting this to happen every year, and that we're expecting our health service to be if not overwhelmed, but then working at it at a kind of extreme? And whether as a population that's what we want, and we're happy with the level of morbidity, and we're kind of just putting up with the ramifications of it. I mean, what is going to happen in the future? I wondered if Anthony, you had a kind of perspective on this. If our government is deciding that this is how we're dealing with Omicron, is that kind of, does that tell us that this is what the future is going to look like, that we've kind of given up? We're vaccinating, but we're not doing anything else.
Well, my biggest worry all along in this, as a paediatrician, has been the long-term effects of the virus on particularly the brain. We know that, with people who get brain fog, who get fatigue, who get cognitive problems, and who get loss of smell and taste is very common. And that basically means the virus is affecting the brain. And in the last week or so, I've been, looking at papers where there's now evidence that the T cell response to this virus can be quite dysfunctional, or T cells get damaged in the same way that HIV, another RNA virus, damages T cells and immunity. We know that the virus can get into the brain, if not so much into nerve cells, but into cells surrounding the nerve cells called astrocytes. We know that the virus also affects cells around blood vessels called pericytes. This gets into every organ of the body, but in the brain, it can have long-term effects. Now, as someone who's had some long COVID symptoms for the past 6 months, I'm beginning to think, how long is this going to last? Or is this a permanent kind of mild disability for me? But what's the implications? Because we've allowed millions of children in this country to become infected with this virus, which, as Aris said earlier, there's no real hard evidence that it's less virulent than Delta in the absence of vaccination. Our children have not been vaccinated. And it's only with time and with growing, scientific interest, we're going to learn what the impact is on the brain. And, Martin mentioned the Epstein-Barr virus now being thought to cause multiple sclerosis. We know that chickenpox causes shingles. We know that measles causes, in a few children, very nasty neurodegeneration. We know about Zika virus destroying the brains of babies. Viruses are risky. And what worries me about this is just the scale of this virus and its long-term impacts for children.
Thank you very much, Anthony. Let's invite some more live questions then. I've got Nigel Nelson from the Sunday People here. Nigel.
Thanks, Alice. if you were to buy a lateral flow test on the open market, it would cost between 10 and 30 pounds. So what would be the effect of the government ceasing to give them out free? And would that be a mistake?
Thank you very much, Nigel. Good question. We've seen how useful they've been over the Christmas period. Martin, were you looking as though you might want to answer this?
Well, I've been involved in some discussions with colleagues. I've been talking on ABC in Australia and elsewhere, because in Australia there's been a big debate about the tests are not free there. There's also a debate in the US. I think at the present time it would be really catastrophic, actually, for all sorts of reasons. It would widen inequalities. It would potentially create a black market. Because you would get ones that we already have seen how with the testing for travel, there have been a number of companies that have been coming in that have been highly disreputable. It would be, it's really exactly the wrong thing to do at a time like this. And, you know, I've been very critical of the response in the UK in many respects, but I think the testing has actually been one of the things that's gone down very well. And I've strangely found myself actually defending the country in that respect in discussions in a number of other countries. So I think it would be all round a bad idea at the minute. But, you know, it's being floated, and I'm not even sure that the government is serious about doing it, because what worries me is that you get a briefing, an unattributed briefing to a journalist, and then it's rolled back. And when I've been asked in the UK media, because I've been commenting on the situation in other countries, but one of the things I've now started to do is to say that, like ministers, I'm not going to comment on leaked documents or leaked briefings. I think the government needs to say what it is intending to do. It should say it to Parliament, and not in an anonymous briefing to somewhere else, because I think this raises much bigger issues, because otherwise we're all just getting confused, and it creates panic, it creates potential for hoarding, all sorts of undesirable things. So yeah, it's a bad idea, and it's being handled badly, even though there's no real suggestion that they're not going to be free.
Thank you very much, Martin. Does anybody else want to comment on the idea of paying for tests?
Why are they 10 to 30 pounds? And that's a big range. Yeah. My question is, why aren't we getting this price right down and producing it competitively? Or is this some crony deal?
They are very cheap, actually, in many countries. I think what's happening in the UK with the ones for travel is they're the supervised ones, and you're getting the additional cost of supervision and recording. So I don't think, you know, I think they would be much cheaper if they were available. But even so, you know, it's still a bad idea, because even a tiny amount is a lot of money for some people.
Yeah, I mean, it still raises that issue of inequality, doesn't it? You know, if the cost of living's gone up anyway, people are struggling to pay their energy bills, which are also on the rise. This is just one more thing. Zubaida.
Well, exactly that. I mean, this is a pandemic of inequality. So there's two broad areas here. First of all, testing is literally the only measure right now that is keeping children safe in a very small way, and it's predominantly, you know, secondary schools. So getting rid of testing and certainly introducing testing means that there's not much else keeping predominantly unvaccinated and under-vaccinated children safe. So that's one thing. The other, of course, is this will hit those on lower incomes the most. There's no question about it, that if you start charging, it will be the more privileged, the better off, who are able to protect themselves and their loved ones, whereas those on lower incomes won't be able to. There'll be no way of gauging whether they've got the virus or not, unless they're very symptomatic and it's very obvious. So once again, what we'll have is a pandemic of not only inequality, but a pandemic of increasing inequality.
How would you feel, Zubaida, if there was a suggestion that perhaps people who got free prescriptions got free tests? Because we already have that system in healthcare. So we already have a system in healthcare where we do pay for prescriptions, but there's an availability of prescriptions for people who cannot afford to pay. Helen?
Yeah, I think that's not a great idea, because there's a huge number of people who don't get free prescriptions who possibly do need them. You know, there's lots of people who are not on benefits who need who still who are not entitled to free prescription, but nevertheless don't have their prescriptions, or don't choose which inhaler to get, rather than getting both of them that they need because they don't have the money. There's a whole nother question to have about whether England should go the same way as Wales and Scotland and actually have free prescriptions altogether, and whether we might actually save a huge amount and improve health by doing that. I think adding lateral flow tests into this mix would just make things a whole load worse. I don't think it would help.
Thank you very much, Helen. Zubaida, do you want to comment any further? Steve,
no,
Aisha, and then Martin and Susan. Okay, so Steve, Martin, then Susan.
I think over time, it's become clearer and clearer how important lateral flow tests are and how effective they are. There have been 2 points recently where there were real concerns about spikes in infection levels, and they didn't happen, and they probably didn't happen in large part due to self-testing. So I already referred to what happened over Christmas and the huge use of self-testing, and how probably that's a major factor in determining the fact we're not in a bigger mess than we are at the moment. The other time was during COP26 in Glasgow, where there were huge fears that the vast numbers of people there would lead to spikes in infection. But there were very vigorous procedures to self-test, not only amongst the delegates at COP26, but also amongst the protesting crowds, who had very strong norms of testing before they went to events to protect others and protect the vulnerable. So I think self-testing can be really valuable. And I think there's a very strong case that instead of talking about vaccine passports, which raise all sorts of complications and resistance and so on, to lay emphasis on self-testing. But there are 2 problems. The problems aren't technical, the problems are behavioral and social. The first is it's really important to be clear about how to use the tests well, about swabbing the throat as well as the nose, about the procedures which will give you an accurate outcome. And I think we need much more information about that. And the second thing, and we've known this from the beginning with testing in general, is that if people can't afford to be found positive because they can't afford to self-isolate, then they're not going to do the tests well. And it's very easy not to do the tests well if, as I say, you're not in a position to find yourself as positive. So yes, the tests are really valuable. And yes, the tests can make a huge difference, but I think their effectiveness depends upon the 2 things that are always necessary to translate motivation into action. The first is information, and the second is support, in this case, support for self-isolation. And if you put that package together, I think we have an incredibly effective tool to help us keep infections down.
Thank you very much, Steve. Brief comment from you, then Martin, and then Susan.
Yeah, I'm just jumping in because, I've written about the importance of universalism in all sorts of ways elsewhere. If you have anything that's other than a universal service, then you get into all the issues of transaction costs, the potential for abuse. People will ask for tests for their grandmother, that sort of thing. It really becomes very problematic. And just look at the taking away universal child benefit, for example, and the complications that led to. And the second issue, which I think is as important, is that it divides, something Steve has talked a lot about before, it divides us, because it then becomes very easy for certain politicians who want to exploit divisions in society to say to some people, look, you through your taxes are paying for them, and them are other people who look different and all the rest of it. And I think that's really corrosive in society. So I think there's a number of arguments that I just wanted to jump in there.
Thank you very much, Martin. And Susan.
Slightly different tag, but evidence is very clear that not any one of these measures, whether it's tests or vaccination or anything, isn't going to be sufficient for dealing with Omicron. And one of the effective measures are face masks in indoor spaces. And increasingly evidence has shown that what are called FFP2, that higher quality masks, or in the States, N95 masks, are significantly, hugely, by many orders of magnitude, more effective than the more flimsy medical or surgical masks or the cloth masks. Now, President Biden in the States last week has announced that they have stockpiled 750 million of these high-grade masks, and they're going to begin giving these out for free. And they are more expensive than other masks. So in view of the inequalities and in view of the fact that health professionals, social care workers, many of the people who've actually been on the front line haven't been provided with these adequate masks, I would suggest our government should take a leaf out of Biden's book and do the same thing here and provide them for the population. Because we're at a situation now where we need everything we can to get these infection rates right down and protect the most vulnerable in our society.
Thank you very much, Susan. I can see Helen waving her masks. What masks have you got there, Helen?
Okay, so this is what's called a fluid-resistant surgical mask. Okay, and the problem with it is it got lots of gaps. It's got lots of gaps everywhere. So it's quite good at protecting the person directly in front of me and stopping me breathing over them. It doesn't really stop me breathing in what they've breathed out, and it doesn't stop my viruses getting out. This one, actually, they're not terribly expensive. They're about 50p each if you buy them in bulk, so they're not massively expensive. This is an FFP2. It's much more closely fitting. Okay, and I don't know whether you can see, but if I breathe in, you can see that the air is actually going through the mask rather than coming around the edge. So the air is filtered. What I'm breathing in is filtered. What I'm breathing out is filtered. Much, much better protection all around. Not terribly expensive, very easy, very comfortable to wear, really not a problem. And much easier if you've got glasses, by the way, because they fit to your nose, so your glasses don't steam up in the way they do with the blue ones. So we're making sure that everyone in our surgery has these for all clinical contacts. I'm suggesting all the local schools have them for all their teachers. We really should be having these as minimum.
I believe a study has just reported that women find men more attractive in masks than not wearing masks. It's reported in the Guardian today.
Right, that's definitely going off on a tangent there, Anthony. Let's rein it back in again. Thank you very much for all of those responses there. Thank you, Nigel, for your question. Let's try and squeeze in a few rapid fire questions here. Eleanor Davidson.
Yes. Yeah. Hello. My question is, can we still exhale live virus and infect people if we test positive more than 10 days after infection?
Great. Thank you very much, Eleanor. Who would like to answer that one? Steve, is this a question for you?
The bulk of people at that point, it's very difficult, even if you're picking up PCR detectable virus, to show that there's infectious virus, but it can happen. And it does depend largely on the course of your disease. So we're all individual, and some people can shift the virus in a short period of time, and some people take longer. So if you are still testing positive on a lateral flow, I would advise caution. And I think that's absolutely one good reason why this 5-day rule is a little short-sighted, to say the least.
Thank you very much, Steve. Thank you very much for that question, Eleanor. Another question then from Vivian Rivis. Vivian.
Hello, thank you. Several people we know report having had COVID-19 2 or 3 times, with episodes of possible infection with different variants coinciding with the first peak, Delta, and now Omicron. Given the lack of testing early on and a lack of PCR test results for every one of these infections and some persistent symptoms, how likely is it that some people have in fact had all 3 variants? If they have, despite now being fully vaccinated and presumably having COVID-19 antibodies, will they continue to be susceptible to new variants?
Thank you very much, Vivian. Who would like to have a go at that one then? I wonder if that's one for you, Aris.
So it's a hard question to answer in terms of numbers, because our systems are not really set up to record reinfection. I've certainly heard of many such reports of people who've had 2 or even 3 doses of vaccine and have been infected 2 or even 3 times. I see no reason to think that such individuals would not continue to be infected in future. But getting a handle on what that number is as a proportion of the population and what the implications of those reinfections are in terms of severity is very much something to keep a close eye on, and see what happens. We're not really in a position to say very much about the relative severity, for example, of future reinfections for someone who's been exposed to that many different challenges. We would like to think that severity would be reduced in future.
Thank you very much, Aris. Does anybody else want to comment on that? Thank you very much for that question, Vivian. And let's squeeze one last one in. Neil Gardner.
Good afternoon. What is the view of the small Japanese study published last week showing that the highest viral load shedding for Omicron is approximately 3 to 6 days after the start of symptoms, and the implications for length of isolation periods?
Thank you very much, Neil. Steve, this very much ties up with what you were just discussing.
Yes, that's one of the studies I was thinking of. There have been others. That peak is, generally speaking, in terms of the RNA that was measured. People that had symptoms were more likely to have culturable virus from their upper respiratory tract at that point. And what was more concerning is perhaps that some people that had symptoms did still have culturable virus later on, much later on, sort of up towards day 9, 10. And remember, this is a very small study. There are bigger ones going on. There is a risk. And of course, it just comes down to exposure again. We need the prevalence to come down.
Thank you very much, Steve. Helen.
I just want to say that in our experience, having had lots of staff coming and going, very few of them have had negative lateral flow tests at day 5 since symptom onset. There are a few people who only got their diagnosis or only got a swab because they were relatively asymptomatic, maybe several days after they were infected. So it's possible that 5 days after that, they're actually way further down their infection. But I think, what we're finding a lot is that our staff are not actually lateral flow negative as long as they've done nose and throat at day 5, 6, 7, or even 8. It's actually much later on that it becomes negative. So it's possible that the day 5 might let some people out because their diagnosis came a long way into actually being infected. But there is this worry there's going to be pressure on people to get back to work soon, and that's my concern. Sorry, Steve, am I?
So it does sound, it does sound like a really risky plan, doesn't it, to reduce isolation just to 5 days? Could we hear from Christina and then Steve?
Yeah, I just kind of want to say that, I mean, even if the idea is that lateral flows catch the people who are still infectious at 5 days, and that may well be the case if you assume that there's no pressure on people to go back to work, which there is, and we absolutely know there is, and we know that again is an inequalities issue where some people have more pressure to go back than others. But the other thing is that ultimately it's a bit like the pandemic, where what the government's trying to do is legislate away the inconvenience of having a pandemic, and you can't do that. You have to tackle COVID. Like, you can't legislate the infectious period of a virus. I mean, it's just bonkers. So this kind of consistent reduction, like, it's not, it just seems crazy to me. That's what I think.
Thanks very much, Christina. I mean, I think it's, it's very clear that it is a policy and economics led suggestion rather than a science led suggestion. Steve, you get the final word. Steve Griffin.
Well, I was going to say the same thing as Christina, but as an additional thing, people have got quite selective amnesia here. The reason that SARS coronavirus 2 is a major problem is because it spreads asymptomatically or pre-symptomatically, and it's really hard to keep track of if you don't have effective testing. That's how it got out of China in the first place, and it's how it spread across the globe, even with all the surveillance that we have. So if we stop looking, we won't find it. It's that simple.
Thank you very much indeed, Steve. Thank you, everybody. I'm going to wrap it up there. Thank you to the press and public for joining us, and please continue to send us your questions and to follow us on Twitter. So thank you to the entire team, and particularly to our 2 new members, Stephen Griffin and Aris Katsarakis. we're very lucky to have you. And I'd also like to announce that Professor Carl Friston is taking a sabbatical from Independent Sage for a few months. He will be missed, but we hope that he has a great sabbatical. Independent Sage will be back with a briefing, same time next week. Stay safe and keep well.
Thanks, Alice.
Bye.
Cheers.